last session in this series of seminars, according to the program, deals with conscience. And we will indeed deal with conscience. Let's ease into it by continuing the previous discussion about a variety of ethical issues in the medical context. And then before we break, swing back to broader issues having to do with the word conscience. At the outset, reminding us of the phrase I think I started with at the very first session, which was something like, when in doubt, do the right thing. You may be a very good group of students. You seem to have a lot of trouble figuring out what the right thing is. And maybe that, of course, is the way I have structured the situation. And a little bit it's for fun, but a lot it's because I think that that is the reality that I perceive. Many of the issues that we have discussed in the first group of seminars, and we'll conclude with today, could easily be subsumed under the heading of conflicting values and what is to be done in the presence of conflicting values. So we spoke about health care, and we spoke mostly about macro issues, and I want to use the little time now to talk more about micro issues, the relationship between one doctor and one patient. Let me get a couple of things out of the way initially. I have spoken about a competent adult patient. The word competent, you will notice, quickly ties in with the value of patient's autonomy. If you have genuine respect for the values of the patient, then it is exceedingly important that the patient be able to articulate what are his or her, in fact, relevant values. So, for example, in a severe burn case where the patient has been badly traumatized and brought into the burn unit, and the patient says, I want to die, leave me alone, no competent physician who respects patient's autonomy will even listen to that because of the immediacy of the trauma, because presumably a great deal of pain medication is on board. If you want to know what the patient thinks, then it is important to know what the patient thinks, and the patient has to be competent to give you a valid consent or to give you instructions or something like that. What that then ties in with is the notion of advanced directives, which the words that you will have heard in public discourse, the most common, I suppose, is living will, and the one that I like best is called the durable power of attorney for health care. The basic notion is that if a patient's autonomy, my values, my rights, it's my life, entitles me to give instructions to my caregiver, I have that right also when I become incompetent later, if I have exercised it carefully and precisely at an earlier stage. In a word, a living will, which I frankly think is not the way to go, attempts to anticipate the future. The better option is called a durable power of attorney for health care, which may be available in some states but not in all states, which lets you pick the person whom you would like to make your medical judgments if you become incompetent. Of all the people in the world, you, upon reflection, decide that your daughter Sally, who lives in the nearby community, is that person who best reflects your own ethical, moral, principle, philosophical views. And in states where it's permitted, Rhode Island is one, you execute a document which says she gets to make the decisions. That's the better way to go than the so-called living will, because things roll in medicine. The situations change very much. Someone will say, let's begin a certain therapy, and if in 4 days it doesn't work, we go to another therapy. And rarely, if ever, can a document anticipate in advance all of the complexities. It is better, in my view, to identify a person who should make the decisions for you. Notice, by the way, how that suggestion on my part, I mean, it's quite beyond me, eliminates some of the toughest questions we've been dealing with. What to do when values conflict? Answer, find out what the patient really wanted. No. What to do that's good? No. Find out what the patient really wanted. The patient's wishes are the criterion. And the shotgun example of a little while ago suggests that that is not unproblematic. So there is the issue of who shall decide, and then there is the issue of what decisions are tolerable within our society and what decisions are not tolerable within our society. AMA, you all know what that means. Yeah, what? Nah, it means against medical advice. The patient discharged herself against medical advice. She listened to the doctors. They said, we need you in the hospital. She said, I'm leaving. I'm going to another hospital. I'm going to a faith healer. I'm going home. They tried to persuade her. She's an adult. She's competent. She left against medical advice. Many of the hard cases that you know about and that we will grapple about occur in the context in which it is physically impossible for the patient to leave. The patient then will say things like, I am trapped by medical technology. And that, I think, is at least a challenge to which we need to be responsive. It's easy, relatively easy, to say, who shall decide? We need to be sure that that never hides from our view the actual value choices when we say what decisions may be taken. What is it that the agent or the one designated by the document may or may not agree to? All right. So to give you a very real case, which has been published, but which occurred in a hospital that I'm somewhat affiliated with. The patient was a 75-year-old, extremely educated woman. She had a PhD. She had been a college teacher. She was, as they say, with it completely. She had all her marbles. She had, which is not surprising at age 75, significant difficulty with her hip, and she was a candidate for a hip replacement. The woman had significant lung disease, such that there was a very real possibility that the hip replacement might go beautifully and that she might be left in an extremely compromised manner by virtue of the lung problems, which might well occur after the anesthesia. What she said she wanted, this had all been explained to her, and she was the model competent patient, and what she said she wanted was, she knew the risk, she wanted the hip replaced. Because without the hip replacement, she was restricted to bed and bedpan, and a very, very unpleasant quality of life she felt. Query, does it matter whether we agree with that part or not, but a very difficult quality of life. And the hip replacement as such, she had every reason to think would go well, would meet the need to get her mobile again. But there was the risk that she could be permanently attached to a ventilator because of her lung disease. She said to our pulmonologist at a certain point, I want to go with the hip replacement. I want to take the risk. I do not want to spend the rest of my life. And also, she said, I do not want to spend whatever inheritance I'm leaving to my children. I do not want to spend the rest of my life on a machine in this hospital. I want you to draw up a document which will release you of all liability and release the hospital of all liability. And I want you to agree up front that if I cannot be detached from breathing assistance machinery after 2 weeks or some very specified time, you will pull the plug and be done with it. That's a tough case. I think it's right on the borderline of a competent, sophisticated patient who knew what she wanted. It is plausible to me, though that's not supposed to matter, but it does, right? It is plausible to me that a reasonable person would want to take the risk of the breathing, the lung complication, in order to not spend years restricted to bed and have some sense of mobility and stuff, especially a bright, able woman who had done many things in her life. She wanted the hospital to guarantee that she would not be kept alive beyond a fixed point in a certain way that she considered unsatisfactory. The physicians were prepared to go with it. Ultimately, the hospital refused. And I don't know the end of the story. But the end of the story never matters in these businesses anyway, right? Suicide. Involuntary. Voluntary. Assisting suicide. Euthanasia. Voluntary euthanasia. Non-violent. Active. Passive. Withdrawing. Withholding. We seem to have established by this point in time in the United States that an adult competent patient has the right to refuse treatment and leave the hospital if he or she is able to do that. Which is not to say that that is always easily available, but at least for people who know how to push, that seems to be well established in many places. Whether the patient can insist on a particular form of treatment or lack of treatment while staying in the hospital remains to be seen. We discussed much earlier on the Jehovah's Witness, the adult Jehovah's Witness, who says, I know what you do in your hospital. I want you to do all of what you do as Western medicine. I want all of that, but I don't want, on my religious grounds, I don't want to be transfused. And I will sign whatever documents you all need to effectuate that. One wants to be sensitive to the pressures of the moment. How long has this person had these religious beliefs? Did this person approach the hospital only when in the emergency room, having a conversion in the ambulance, so to speak? But that just means you really want to know whether you're hearing the real wishes, query that, the real wishes of the patient. So the following case presents in a hospital. It is 11 o'clock at night. These things invariably happen before 11 o'clock at night, between 11 o'clock at night and 4 o'clock in the morning. And the resident is called to the bed of a patient he does not know. He is cross-covering, as the expression goes, for another team. The patient has a crummy cancerous condition, and there is now involvement with breathing, and should the patient be placed on a respirator. Given the extent of the malignancy, the resident doc has his doubts that this patient should be placed on a ventilator. So at 11:15 at night, he calls the patient's daughter and says, I am so-and-so, you don't know me, but I'm a resident at the X hospital, and this and this and this is what has happened to your mother, and I need to know whether to start her on a respirator because once I start, they won't let me stop. He said, that is the distinction between withdrawing and withholding. He said, we can now withhold, refuse to put the patient on a respirator, but once we start, we cannot withdraw. The daughter says to him something like, it is 11:15 in the morning, or at night and going into the morning. We are all upset about Mama's illness. I don't know what to tell you. Put her on the respirator. We'll come in tomorrow morning with my 3 brothers and sisters, and we'll sit down and we'll talk and figure out what to do, which I must say strikes me as an absolutely reasonable response of a family person put in such a predicament. The cross-covering resident who had called the private attending physician and, of course, couldn't reach him but received his cross-coverage. So cross-coverage is talking to cross-coverage, and nobody knows anything about what this patient wants. Persists with the view that once he starts, he can't discontinue. Hold on to that case for just a bit. I'll give you a different case. A sophisticated, like us, you know. We've got to be very careful about when we're simpatico to whom and not to whom. Digression. Maybe one of the reasons medicine is different is because you deal with very vulnerable populations. Maybe within medicine, some populations are more vulnerable than others, like nursing home patients who have no living family. Very easy to perceive the view of many that such people are so vulnerable that one needs to be very suspicious when it is said that they have articulated desires this way or that way or the other way. Vulnerable populations. End of digression. A sophisticated, true case, a sophisticated professional guy who had a cancer, had been working on a regular and sustained basis with an oncologist and had had procedures over the years, and they had agreed what would be done if this, what would be done if that. The guy had the misfortune to collapse at a social gathering, the patient, and they called an ambulance, and he was taken to a hospital, and nobody knew whose patient he was, and nobody knew what to do. In an emergency situation, it was quite obvious what to do. They gave him, as they say, the full 9 yards. The full 9 yards, including tubings, intubation, tubings that he had agreed he would not be subjected to. But the emergency room knew nothing about him. The emergency room did the correct thing. When in doubt, it's a 9-yard press, I think. The next day, his physician came in and pulled out all the tubes, to the extreme horror of the nursing staff in that hospital. That's the same case, the same issue as in the case of the lady with the hip, and it is really the same case as the 11 o'clock at night presentation. I think that what the patient's relative said in the middle case is correct, and I think what the doctor did pulling out the tubes is correct, and I think that a language of you may not withdraw, but you may withhold is a word game, as I will attempt to show to you. I think it's a word, and this is not an original point with me. It is well documented in the literature, but it is controversial. Active-passive. The patient comes in with pneumonia, or the patient has been forever in and now has pneumonia. Pneumonia, you may have heard, used to be called the old man's friend, meaning people would say it's a not bad way to die, just let it go. And then, quote, the disease will take its own course. We didn't kill him, the disease killed him. Yeah, but you had penicillin, right? Oh, yeah. Penicillin would have stopped it, right? Right. You didn't use your penicillin, no, but we didn't actively do anything, we just didn't use our penicillin. That's a word game. Who wrote in the chart, no penicillin? I did. So the writing in the chart, no penicillin, is active. The decision to withhold the drug so as to allow death to occur, I think is the same thing as withdrawing the drug so as to allow death to occur. The goal was the same, the intention was the same, the result was the same, and I'm reasonably simpatico in the abstract. Let me give you yet another case to try to make the point again, perhaps more clearly. Perhaps you have seen the movie The Godfather, Godfather 1, I don't know, they've lived through 2 and 3, but there's a movie, Godfather 1. Marlon Brando has a role. Marlon Brando is the underworld kingpin. At a certain point, he gets sick, and they put him in the hospital. The enemy mafia gang sends a guy to, or a whole team, to wipe out Marlon Brando, Don Corleone, right? To wipe out Marlon Brando in the hospital. He succeeds. Go through the movie on your own. I now pick up. First case. One guy with a submachine gun walks into Marlon Brando's room, reads the chart to make sure it's Marlon Brando, the figure in the movie, takes the submachine gun and shoots him, and he dies immediately. Yes or no, the machine gun guy killed Marlon Brando? That's easy. It's very straightforward. Second case, the guy comes in, and there's a nurse in the room. Says, "How do you do, sister? How do you do, distinguished guest? I'll be right with you. Tell me, sister, what's that tube over there?" "Oh, that's his breathing. He's very lucky to be here. We have an advanced breathing apparatus. He couldn't breathe without the tube." "Thank you, sister. That's very nice. I'll sit down and wait till he wakes up." So then the nurse goes off and does her thing, and the guy puts his foot down on the tube. Death resulting. He killed him or he didn't kill him? The same or different than the machine gun case? And in fact, safer, because the bullets could hit a child running by. Third case, the guy comes, and he knows all about the tube, and he's sitting there, and Marlon Brando thrashes and knocks out the tube. The guy runs out and sees the nurse and says, "Hypothetically, if that tube fell, yeah, that'll kill him." Runs back and sits down quietly watching Marlon Brando. The tube, the tube, the tube. He didn't plug in the tube. Did he kill him? Did he want him to die? Did he kill him? Why not? What's passive? He failed to act. If there was a duty to say, if instead of the mafiosi it was a young doctor or an old doctor, if instead of the mafiosi it was one of the treating docs who said, "This guy's had long enough to live and it's time," wow, he's knocked the tube out. Active or passive? The doctor was a treating doc with a responsibility to treat. The patient knocked the tube out, or the tube became congealed with the gunk, and he said, "We don't have to replace this tube so quickly." Did he want him to die? Yes. That's not enough. Did he kill him? I think he did. I think he did. I also think it's not morally distinguishable from either of the other cases. Depending where you are then, that might lead you to a conclusion that none of the above should be permitted. And it might lead you to a conclusion that all of the above should be permitted. To say that the disease ran its own course when we had the capacity to intervene, and we would have intervened if we didn't want the patient to die, perhaps absolutely consistent with the patient's values, it seems to me then plays word games to try to distinguish between withholding a therapy and withdrawing a therapy. There are those who disagree, there are those who agree. I mean, that is sharp in the literature. Is it suicide? It depends how you define it. It's not a word. I'm trying not to be cute now. Depends how one understands the notion of suicide. It may well be a killing, but a permissible killing, if you think some killings are ever permissible. I think the physicians with whom I have had this discussion, and others have had this discussion, are very frequently resist bitterly what I am telling you, because psychologically it seems much easier not to put the tubes into the guy than to come in when they put the tubes in by mistake and take them out. From the patient's point of view, I don't see that there's any distinction. The patient had thoughtfully worked on, back on the earlier oncology case, the patient had thoughtfully worked out with his doc what he wanted done. Somebody made a mistake, indeed an honest mistake. He wasn't known when they brought him in by ambulance. But he didn't want those tubes. A competent patient has the right to refuse medical treatment, even when death will result. I think that that is a defensible position. I have to acknowledge that it is a controversial position. Minimally, we would be careful about competence. Minimally, we would really want to know that we really know what this patient wanted. But at a certain point, you got to say, are there things that the patient can ask of the doctor, and the doctor says no. So the patient is acutely ill, and the patient has been squirreling narcotics in his desk drawer or his hospital drawer. And it's clear what he's doing. They give him heavy-duty stuff, and he spits out some of it into... he's getting up enough to put himself out of his misery. Is it active or passive when his relatives see it there and say, look, George, we just can't let you do this? Is it active or passive if the nurse sees them there and says, look, George, I just can't let you do this? I don't see how the line... Maybe there are things we can't let George do, but I don't see how the language of active or passive will help us. Beyond that, I want to suggest one aspect for your consideration, which I had not thought of until working a bit in a clinical setting. If you say, which I don't want to say, if you say that once you've got the tiger by the tail, you own it. Once you put the patient on a respirator, the considerations are different and you can't take them off. You're going to produce a situation in which treatment decisions are made with very limited information. If the docs in the emergency room have to say, if we put him on a respirator, it'll be hard to take him off, they are likely to undertreat people who could benefit from the treatment. They are likely to undertreat for fear of getting stuck, as opposed to, you begin an antibiotic, you put it on a therapeutic course, and if in 10 days it doesn't work, you try another antibiotic. Put him on the ventilator. If in 10 days or whatever we don't get expected results, take him off. You can't do that if someone is looking over your shoulder and is going to yell murder, and that is likely to present many situations in which patients who might benefit from treatment will be undertreated for fear of how the treatment will not be, for fear of the docs that they will not be allowed to do anything at a later point. Are there situations in which the wishes of the patient are radically different from my wishes or your wishes? Certainly there are. How far to go in observing the wishes of the patient as distinct from the values and norms of the particular hospital or of oneself as a nurse, as a physician, as a specialist? I have heard a hospital chaplain give the following account, which I find very compelling. He was called to the bed of a certain woman who was acutely ill with advanced cancer and could barely speak and was heavily medicated for pain, and the assumption was she was going to say to him, make them leave me alone. And she called him over and she said, my granddaughter is pregnant. I want to live to be a great-grandmother. You can't know how important it is to be a great-grandmother. This woman is racked with pain and has an irreversible disease. She wants to be kept going to see her grandchild, her great-grandchild. I find that a compelling case. Is it equally compelling the other way? The one who says, I want to die quietly now. I don't want to bring any more anxiety or anguish to my children. It's enough already. The same, different? To be absolutely vulgar, and it bothers me even to put this case, on the grandmother who calls in the chaplain and says, I want to see the great-grandma. Should you consider the cost? I mean, this woman's in the intensive care unit. She's running up bills $2,000 a day. She's occupying beds that you need in your hospital for somebody else, and she's sentimental. I told you it would hurt me to say this. She has no financial means of her own that are relevant to this discussion. She wants to have you respect her conscientious wishes, generally so. So, I mean, some things that I will say you know about already. I will say we're going to be really careful that we assume we know what Grandma wants, and upon reflection we know what Grandma wants, and this really is what Grandma is saying. We want good communication, and that Grandma understands. Some people's grandmas on those facts would want to be kept alive. Some people's grandmas on those facts would like to die quietly soon. If one is confident that they are competent to make a decision, do we walk away and look the other way? There are patients in a hospital where they have discontinued drawing bloods, for example, where they're not interested in various kinds of levels. They're providing comfort measures only, as the expression goes. Bringing me to the issue of feeding and hydration and nutrition, the current cutting edge probably of these kinds of issues. There are two ways to go. There are more than two ways to go. There are two dominant views in the literature. One view of tube feeding, feeding through artificial means, is that they are to be understood roughly comparable and analogous to artificial breathing through a ventilator or respirator. And the ethical and religious traditions which will allow the discontinuation of artificial breathing, disconnect the respirator under whatever terms seems appropriate in that tradition, may well agree that artificial forms of feeding are identical by analogy. And whatever would justify taking a patient off a respirator will justify taking a patient off a G-tube or not putting in a gastrointestinal tube. There is another point of view which says that hydration and nutrition is different and that it has to do with basic, most minimal, sort of the safety net of creature comforts to which any human being is entitled. And on that grounds, even though the patient may or may not be able to refuse to have a tube put in, or the patient may or may not be able to refuse to take medication, or the patient may or may not be competent to refuse to have her leg amputated, everybody in our hospital gets fed, everybody in our hospital gets bathed, we would not leave a patient alone in terrible condition. Indeed, it's a scandal when they find patients who have been abandoned. So a good institution says, we don't abandon patients, we treat patients. How can you then ask us to treat a patient and yet let the patient starve? And it is precisely at that point that conflicting moral evaluations and judgments come sharply into view. When in doubt, do the right thing. But it's not a gag line. It is a troublesome recognition that in the United States we have radical distinctions in some sets of values, as we have spoken numbers of times already in the seminar and at the beginning of the semester. So the word to think through in the beginning of the sequence, the word to think through in the little bit of time allotted to us now is to think about the word conscience. And in thinking about the word conscience, I took a look at one of the classics, even though it's recent, of American politics, Dr. Martin Luther King Jr.'s letter from the Birmingham jail. During the civil rights movement of the 60s, Dr. King was arrested perhaps more than once, and at one point was in the Birmingham jail, and some clergy published an ad in the paper which essentially said, too bad these outside agitators came down to make trouble, we'll work out our own stuff here in Birmingham. And Dr. King wrote what may be the most impressive thing he's ever written, or most impact-laden thing he's ever written, a beautiful defense of the obligation to follow one's own conscience. And he says, you ask me, you clergy to whom I'm responding, you ask me how I can advocate breaking the law when as a leader of the civil rights movement, I have advocated respect for the law. That is, I have told the southern school boards and sheriffs and everybody like that they have to agree with and behave according to Brown versus Board and other such like that. And here am I advocating the disruption of the law, the refusal to obey the law. King says, I believe in obeying the law, just law, but a just law deserves to be obeyed, and an unjust law deserves not to be obeyed. So how, Dr. King, will we know which laws are just and are non-just? And he gives some quotations from Scripture, which is fine if you agree with his reading of Scripture, or indeed his definition, excuse me, of what the relevant Scriptures are. And he talks about a just law and an unjust law, and he talks about the importance of following one's own conscience. Stop and play a bit with this word conscience. As King uses it, it's a good guy word or a bad guy word? Clearly meant to be a good guy word. Conscientious people are nice people. Conscientious people will face difficult choices. Conscientious people, think about the use of the word conscience across history. For example, the Crusades, which wiped out entire towns on the way to obeying their religious consciences. For example, a conscientious Nazi who believed in Hitler and believed in the final solution. Imagine two different concentration camp guards, one of whom essentially said, this stinks, but you got to save your own neck at some level, and I, as a concentration camp guard, will do my best to keep my butt clean, and if you want to bribe me to get people out, you can bribe me to get people out. This place stinks. As opposed to a conscientious Nazi who said, I believe, I truly believe, I deeply believe, I'm committed, I wouldn't take a nickel or 5 million nickels to let anyone out of Auschwitz. You respect him for his conscience? Conscience sounds like one of those good guy words until you begin to look at what's hiding behind it. The name I couldn't come up with a half a minute ago was Khomeini. We're old enough to remember him? We're happy that he acted out his conscientious will? Or it would have been better if he sort of was a wheeler-dealer, pragmatist, and sort of cut deals like with us. Historically, it is the case that the name conscience has been associated with things that you would consider despicable and with things that we might consider highly admirable. Conscience doesn't get us out from under the need to make a value choice. How do I know a conscience as distinct from an ego? How do I know a conscience as distinct from a delusion? How do I know a conscience as distinct from a gut reaction? What is it that constitutes something as being conscientious if it is other than it agrees with me substantively? Sometimes we can defer to the claims of conscience of others. Sometimes we have to say, I think, your claim is one I agree with, and that's why I agree with it, and then make out an argument as to why it is that you think Dr. King, if you think this, had the better part of the argument in Birmingham, better than the people that were turning the dogs on the civil rights marchers. But whether Bull Connor, if you can remember, the then police commissioner guy in Birmingham, was a conscientious redneck or simply a good soldier doing his job, it doesn't strike me as attractive if he were a conscientious redneck. And I don't know easily how to distinguish between Dr. King's conscience, which got to a result that I liked very much. I don't know why Dr. King's conscience is inherently or intrinsically deserving of respect as opposed to the set of arguments that would have to be associated with that which he advocated. Conscience can be used to describe many things that I would disagree with very, very sharply. Some part of that problem can be alleviated by a commitment to process values, procedures. Leave some things not to government but to individual choice and autonomy. At an early part in these seminars, we talked about the issues that might or might not require uniformity across time and space. Gambling is allowed, casino gambling is allowed in some places and not allowed in other places. Some places find it very, very offensive, incidentally religiously offensive, to have casino gambling, and other places are happy to have it. That seems to be an issue that the American body politic is comfortable leaving up to the voters of Nevada and Jersey, Atlantic City, New Jersey, and like that. I mean, you know the next case. You knew it at the beginning lecture. Abortion. And if you don't want to talk about abortion, how would you like to talk about sterilization and related kinds of issues? Is it the case that abortion is of a character such that it needs to have a uniform rule at every place in the country? Or is it a phenomenon such that can be left to the political process in one part of the world as opposed to the political process in a different state? There have been in recent times significant obstructions of abortion clinics by, what's the phrase I'm missing? There's a name for the group. Operation Rescue. Thank you. You're happy with them or not happy with them in terms of your belief in the purity of their conscience, or in terms of your political sense of how the abortion issue is playing out and how you would like, as a concerned citizen, to see it play out? Does the fact, I have no reason to think that some number of these people, I have no direct involvement in this, I have no reason to think that some number of these people are acting out of deep conscience, which is precisely why they're dangerous, and they're troublemakers, and they're not going to play by the procedural rules. Does that then make them heroes? Depends on my personal politics. The kind of ethics that we have been talking about for the last 8 sessions moves very far away from substantive correctness. At best, the justification for the kind of teaching that we have, that I have imposed upon you, in these 10 or better 8 past sessions, the justification is as a kind of, so to speak, I don't mean to be arrogant, intellectual traffic cop. If we had more time and if we were working systematically off of texts and if you had access to the microphone as often as I do, we would be able to try to work through this, the ability to analyze problems, the ability to recognize the values that are implicit in problems, the ability to think at a certain distance from problems. And I think those are, I believe as a university teacher, that those are good things to do. When they pick the next president of my university, or any university, they are likely to pay attention to many things and not likely to pay attention much to the content of his or her beliefs. That would not once have been true. At Brown University, we were founded by the Baptists, and for a long time the president had to be a Baptist clergyman. And if I gather, if he were a committed Baptist clergyman, he would know a great deal about the answers to certain kinds of questions. That is no longer true at my university, nor at many of the, or most indeed, of the institutions of higher education which we all look up to and respect. Having said that, it is indeed central to any kind of ethical discourse to know what one's own values are, to know which ones can be held for what kinds of reasons, to know when we can balance off and trade. Remember the George Bernard Shaw joke? We've agreed, madam, that you're a prostitute. Now we're haggling about the price. Fiddler on the Roof, a modern American literary musical. Fiddler on the Roof. So Tevye the father has this problem. You can help me if I don't get this exactly right. Tevye the father has this problem. His daughter has been betrothed in a formal engagement ceremony to a certain person. She doesn't want to marry that guy. She wants to marry her true love. The father's got a big problem because they've announced the engagement to the other guy. So the father, and anyway, the mother thinks it's a wonderful match to the other guy. True love is being driven into the ground. Tevye stages a dream that he's having this nightmare. And it's a big production number, and I won't try to sing it for you. Even I have a conscience. Tevye stages a dream in which his wife's late grandmother, may she rest in peace, came from the other world to say that this match is no good and the other match is the right match. And it goes forward, and they stage the thing, and they do all of that, and they have the wedding. And at the wedding, to the new guy, the old guy who's invited and gives a gift, but he sort of blows his cool a little bit and says she was supposed to marry me, to which the superstitious mother, Mrs. Tevye, says, what do you mean? My grandmother came from beyond the grave to tell us that this was a match made in heaven, to which the answer precisely is, my grandmother came also in a dream, and my grandmother says your grandmother is a liar. Talking to grandmothers is a private form of knowledge. Is a private form of knowledge. How does it enter into discussion in the body politic? How does it enter into our judgment? Some number of things ought well be left to the autonomy of individuals. Some number of things ought not be left to the autonomy of individuals. The discussion today about competent patients hasn't said anything about kids, and I'm not going to get off onto that. Children are, he said, not getting off onto that. Children are different than adults in that at least you can say many times, we really know what Papa's wishes were. He made them very clear. And we defer to Papa's wishes when he is no longer competent. The premature newborn baby in the pediatric intensive care unit can't express any kind of values. Right? So that's a very tough and tricky situation. Having said all of that, child abuse is a reportable offense in Rhode Island, and it should be a reportable offense in Rhode Island. And there are things that parents do conscientiously to their children which constitute child abuse. And we should interfere in our neighbors' lives to some extent, subject to constraints, to limitations on resources, subject to the bureaucratic problems of what to do with kids. And at some point, in a decent society, one says, I am my brother's keeper. On the other hand, There is a cartoon of a Boy Scout crossing a little old lady across the street, and she's hitting him over the head with her umbrella, saying, "I don't want to cross this street." The law calls him a mere meddlesome intruder. That's not 100% right. You may have to come back for another sequence for me to get that right. A meddlesome Budinsky. It's not his business which streets the lady crosses. But sometimes it is, and sometimes it isn't. Why, Professor Beiser, do you answer every question with a question? To which the answer is, why not? Thanks a lot for your attention over a lot of sitting.